Glaucoma is a progressive disease with the only modifiable risk factor being the intraocular pressure. Over the years, tonometry has evolved. We are very familiar with the indentation tonometer. It was very much in use during the early 1900s. Then came the Goldman in 1954, applanation tonometers. Then the Perkins non-contact tonometer, rebound tonometer, then the dynamic contour tonometer, transpalpebral, and many newer additions like implantable sensors which can be kept inside the eye for intraocular pressure recordings. However, Goldman applanation tonometer remains the gold standard for intraocular pressure measurement, and we will be talking in detail about the errors encountered while we do Goldman applanation tonometry. We all know that it is based on the imperfect principle, which says that the pressure inside a perfectly thin round sphere is equal to dry sphere, is equal to force divided by area where the force is applied to applanate the sphere. However, eyeball is not a perfect sphere, and there are other factors acting on the surface of the cornea like corneal rigidity and capillary attraction. So Goldman found that at an applanating diameter of 3.06 millimeters, the corneal rigidity and capillary attraction cancel each other, and at this point the intraocular pressure is recorded. So we know that in the tonoprism there are two biprisms, and the biprisms form semicircles, and the end point is when the inner margins of these semicircles just touch each other. Just brushing through the procedure, the conjunctival cul-de-sac is anesthetized with paraffin. Then the conjunctiva is stained with fluorescein to make the semicircles more prominent. First, the tonometer head is pulled away from the patient so as to decrease the impact and injury, to avoid injury to the corneal surface. Then it is slowly advanced with blue illumination falling at around 60 degrees at the tip of the tonometer. It is gently advanced forwards. If the lid is coming in the view, we can just gently pull up the lid without pressure on the eyeball. And when the inner margins, we have first the knob is set at 1, which corresponds to 10 millimeters of mercury pressure, and gently the knob can be rotated clockwise or anti-clockwise, and when the inner margins just touch each other, we record the pressure. So what are the errors encountered usually in our clinical practice? Let us brush through the procedural errors. This is something which we see in our routine clinical practice very regularly, like especially in old patients when the head alignment is not proper. The chin should be placed securely, and the head should be touching the headband. The eyeball and the tonometer, your head should be in this same line. So if this is not in line, it can result in either the upper or lower Myers looking like that, smaller or bigger than the other. So faulty head position is one. Another factor is this, what we are seeing here in this picture. You see that the ball bearings of the pivot has rusted, and the ball bearings are worn out. So the pivot of the tonometer won't be in the right position, and that can result in abnormal movement of the tonometer head. This also can result in misalignment of the tonometer unit. This is another scenario when there is excess force applied by the tonometer head on the corneal surface that can result in overriding of the Myers, and the inner margins are far apart from each other because of the overriding. In this case, the pressure inside the eyeball will be much lesser than the force which we are exerting on the surface. We have to gently pull the tonometer unit away from the eye and adjust the knob also to decrease the force and measure the intraocular pressure. The second scenario is when lower force is applied on the corneal surface by the tonometer head. The semicircles are much smaller and they are apart from each other. So we have to gently bring the tonometer head little forward and rotate the knob. Also, usually it has to be rotated clockwise to increase the pressure, because the pressure inside the eyeball will be much higher than recorded in the second case. Now coming to staining errors. Excessive staining or insufficient staining can occur during the procedure. Like excessive staining when the fluorescent dye is more and the patient is also watering, the conjunctival cul-de-sac will be overstained. At this point, when we are checking the intraocular pressure, the mires will be wide, very wide than this. Ideally, the mire size should be 1/10 or 10% of the diameter of the arc. So in this case, the mires are much wider, and when we are checking the pressure, the tonometer knob should be rotated clockwise, and it will be an overestimation of intraocular pressure. Whereas if the stain is insufficient, as in evaporation of the dye from the cul-de-sac, or when the watering has caused the dye to flow away from the cul-de-sac, the mires which we get will be much narrow. So we may have to decrease the force applied, and anti-clockwise rotation of the knob may be required. This can result in underestimation of the intraocular pressure. Then another factor is corneal thickness. So ideally, when the tonometer was designed by Goldman, it was set at a corneal thickness of 520 microns. So later it was found that there was variation in corneal thickness, and for every 40 microns variation, 1 to 3 millimeter mercury pressure difference of intraocular pressure may occur. So in thin corneas, this can result in underestimation of pressure, and in thick corneas, this can result in overestimation of pressure. So this is significant in conditions like normal tension glaucoma and post-refractive surgery patients, where the corneal thickness will be much less. And in thick corneas, like in ocular hypertension, also the thickness will be higher, and the intraocular pressure recorded will be high, abnormally high. Another factor which can cause errors in intraocular pressure measurement is astigmatism. So it is noted that with the rule, astigmatism will result in slight underestimation of pressure, and against the rule, astigmatism can result in slight overestimation of pressure. At a particular range, above a certain range of astigmatism, the mires will be so distorted that proper intraocular pressure measurement may not be possible. Usually more than 3 diopters of astigmatism if encountered, mires will be much distorted, and it is better to take an average of 2 readings which are 90 degrees apart, or you can align the red line of the tonometer housing with the minus axis of the cylinder, and then record the intraocular pressure. Other factors which can alter the intraocular pressure measurement are corneal rigidity. Another thing is in corneal edema cases, when the cornea is boggy, even though the thickness is high, the intraocular pressure recording will be much low. And in scarred corneas, it is noted that if there is scarring, the intraocular pressure recorded will be falsely high. Thus we all know if there is a pressure effect on the eyelids, like while measuring, if we are pressing on the lids, or if the patient is squeezing his eyelid, and in foreign countries, like if there is a tight collar, all these conditions can cause high intraocular pressure. Also, restrictive pathologies can also result in high intraocular pressure recordings. Now, repeated tonometry, when we are checking the intraocular pressure again and again, we note that there is a lowering effect of intraocular pressure. This is due to a massaging effect on the corneal surface. Now, something which is very important is calibration of the machine. Technical factors like ideally it should be done before each clinical session. The glaucoma consultant of the clinic should do periodic checkup of all the tonometer units in the clinic to check for calibration errors. Actually, the manufacturer provides the calibration rod and an adjustable holder with it. The calibration rod has markings like 0, 2 and 6, which corresponds to 0, 20 and 60 millimeters of mercury pressure. So the tonometer unit has a housing or an axis into which this unit can be slit into at the axis of the tonometer, and we have to set the when we are checking for 0, the marking should be the holder should be at the 0 marking, and as shown in the video, we have to rotate the knob of the tonometer recording either clockwise or anti-clockwise, and when it is rotated clockwise, the feeler arm will rock forward, and when it is rotated backwards, the feeler arm will rock backwards. This is repeated at 2 and 6 as well, which corresponds to 20 and 60 millimeters of mercury. Then according to the Southeast Asian glaucoma interest group, small errors of 2 plus or minus 2, 3, 2 for 0, 3 for 20 and 4 for 60 is considered as within normal limits, but if it is more than that, it is better to send the calibration unit to the manufacturer for calibration. So many studies say that there may be errors due to other factors like dust settling inside the tonometer unit, or rusting or lubrication problems inside the tonometer unit. So when we are sending to the manufacturer, these areas are checked and it should be corrected. So the take-home message is, a watchful eye of the examiner can save the vision of a patient. Thank you.